Okay, we should be set. Hey, Zavin, you're here. Can't hear you though. Today is going to be clinical problem solvers via mime then from Zavin if he can't get it ready. Kiara, how are you? Great to see you.
Hey, I'm fine. I'm so happy to see you, all of you. I'm doing great, exhausted, but great. Also, it's been a while since I don't join all of you, but I have a case. I'm actually like in clinical rotations, and if you don't have a case, I can share one with you.
That'd be great. That'll be fantastic. We'd love to hear that. And if anyone's interested in jumping in the discussion live with us, please speak up. We'd be happy to have some helpers with the thinking out loud as we hear Kiara's case. How are your IT issues, Zavin? Holding us in suspense. Cool. And Jan, I know you're scribing for the first time. Have you gotten a chance to like say hi to the whole crew and everything? You might be.
I'll go ahead and
go for
introduce
it.
myself.
Please do.
Yeah, for sure. Hey everyone, my name is Jan Dela Cruz. I'm a fourth year about to graduate from LECOM down in its Bradenton campus. I'm on my teaching elective this month, so part of our responsibilities is scribing. So I'm really excited to join you all today. It'll be my first time. Something I guess not so cool about me, but I always share is I'm from Jacksonville, Florida, and in my heart, it's the greatest city in the world. But I'm a big fan of the Jacksonville Jaguars. They are an awful football team, so it really does build character. But I would be remiss if I didn't mention my Jags, so go Jags.
In some ways, it's like, it's fun to vote for an underdog, right? Like for
Absolutely.
Awesome, Dan. Great to see you.
Can y'all hear me now?
Yes, yeah. Yeah,
Cool.
Alex pointing out the Texans can just hang right there with your Jags, Jan. Yeah.
That's for sure.
Great to meet you, Jan. Thank you for your help today.
Absolutely. Thank you for having me.
Yeah, if anyone's interested in discussing with us, that's what we're waiting on. We can also kind of jump in and pull from people's thoughts in the chat. What do you think, Zavin?
Yeah, just get into it.
Okay. So we will turn the screen over to Jan and Valeria and Kiara. We're excited to hear your case.
Okay. So hi again. Okay, so I can start with the chief complaint is abdominal pain and melena. Maybe you can discuss with this information, or maybe I can go further.
We can. Do you want us to make a couple quick comments?
Yeah, could be. So this is a 44-year-old male whose disease started like 7 days ago. He started with abdominal pain localized in upper quadrants, and 3 days ago his abdominal perimeter started like growing, and he persisted with that pain. Also nausea was added, but he never got to vomit. He also had like a sensation, a burning sensation in the thorax, and the day he came into the emergency department, he went there because of the persistence of the symptoms and increased abdominal perimeter. So, and also of course the melena.
Okay. Let me just make a kind of quick comment on kind of thoughts on GI bleeding in general. Zavin, then I'll kind of toss it over to you for kind of this case. But I think what's really interesting about GI bleeding is the same way that Aaron has taught us with neurology. There's a localization issue, and then there is a question of why is the problem happening in the first place. So hearing melena, we're imagining we're worried about upper GI bleeding. And as you guys know well from your experiences in other cases, there's a lot of potential sources to get bleeding in the upper GI tract. starting all the way, in fact, from the nasopharynx. Blood can drip down and cause melena if there's significant posterior nasal bleeding, but mouth, esophagus, stomach, duodenum, and parts of the small bowel also. So the endoscopy helps us find the problem, right? We can see, is there an ulcer, a peptic ulcer disease in the stomach? But I think what's really fun about GI bleeds is once you find out where the problem is, figuring out why is the problem there in the first place. So if someone who is found to have a peptic ulcer disease, thinking about the many reasons that could happen and pushing your differential diagnosis beyond localizing the source of the bleeding to figure out why that problem there is in the first place. Like I said, in the case of a peptic ulcer disease, right? Is it related to medications like NSAIDs? Is it related to H. pylori infection? Is it related to excessive gastrin production in Zollinger-Ellison syndrome? So shout out to Aaron and the kind of localization in neurology, but I think GI has a lot to learn with that, with finding where the bleeding is starting from, and asking why it's happening in the first place.
Thanks, Steph. So you kind of like talked about the bleeding. I guess maybe I can just think about the abdominal pain with the group, and I'd love to like just hear or pose the question of like, how is belly pain with GI bleeding different from painless GI bleeding? Which causes of bleeding are prioritized, and yeah, just what do people think about that difference? And please, we got a lot of people that are very experienced in this venue. Feel free to comment in the chat, but if you just want to unmute and say as little or as much as you want, please feel free. So some great thoughts coming in, and hopefully everybody's seeing the chat, but just those of you who might just be listening or commuting or something, some of the like painless causes, right, that we think of, things like diverticular bleeds, extremely common, right? AVMs, arteriovenous malformations, and other vascular sort of abnormalities that just sort of bleed out of the blue. In the upper GI tract, things like, varices in the right patient, things like doulofoid lesions. I mean, most GI bleeding is actually painless, right? So when you have pain and bleeding, you kind of can actually, or should, I would say, start thinking about the differential a little bit more closely than we do for most GI bleeds. Because honestly, like, over time, right, with experience, when somebody comes in with a painless GI bleed, I actually you end up like not perseverating on the differential that much, because they're going to be scoped, and that's where the answer is going to be, right? But in this case, it can be helpful to kind of be like, okay, well, what things can cause painful bleeding? And some people are mentioning, ulcers, especially with perforation, get prioritized. Absolutely, right? Mohammed mentioned cancer. So the time course there would be really important. If there's been this like subacute, chronic, progressive, aching, pain, and now there's a bleed, that would absolutely be, a concerning story. And then like the spectrum of inflammatory disorders, right? So whether that's IBD or, something vasculitic that is affecting GI blood supply, or honestly, something non-inflammatory but vascular in terms of mesenteric ischemia specifically, colonic ischemia can classically, present with pain, diarrhea, followed by some bloody stools. And by the way, keep in mind that, even though we associate melena with upper GI bleeding, you can have colonic bleeding that comes out black if it's starting, in the more proximal colon with slower transit and stuff. So that's not a perfect localization to say melena equals upper GI, hematochezia equals lower GI. Thank you for those thoughts. Now moving on a little bit to sort of the details of his HPI. So pain started 4 days ago, burning almost feels like it's in the chest. and then some abdominal distension. I think the abdominal distension is, to me, isn't that discriminating. On the exam, it'll be helpful to see, is this mostly distension with gas, right? Does it sound very hollow? Or is there a minimal gas pattern? And instead, this is distension with fluid, perhaps, right? If it's acute. But in terms of where the pain is, it does seem to potentially localize to the stomach and duodenum. Although keep in mind that the transverse colon is there too. So if there's an inflammatory process of the transverse colon, you could have tenderness there as well. What other thoughts in the chat here? Steph, did you see anything that I missed that you want to emphasize?
No, I was just kind of asking the same question of the group, kind of the increase in the abdominal girth, what does it go with? But I think you're right. We're going to know on exam, is it fluid? Is it gas? And by the way, is that fluid ascites, or is there hemorrhage also inside the abdomen? We probably just don't have enough information to go now. And the bleeding and pain syndrome is really kind of most critical. Richard's making a really good point that blood is very cathartic in the GI tract, meaning it makes things move along and progress. And so just the fact of having blood activating and moving the intestines along, making them more active, could cause its own discomfort. That's such a good point, Richard. Thanks for bringing that in there. Chiara, I think we're ready for more.
I'm excited. I love the discussion. Okay, so I will go further with some medical history. So he had pancreatitis in 2015. He also was diagnosed with seminoma in 2017. He received chemotherapy and orchiectomy, and he was discharged because his disease was gone. He also got COVID in 2020. He was diagnosed with allergic rhinitis in 2021. And at that same year, he had a new finding in the other testicle, but he defers the orchiectomy, which was a suggestion by his doctor, and he decided not to have that orchiectomy. Actually, he was taking albuterol because since COVID, he had like some bronchial hyperactivity, but he was just taking like on demand. He is married. He has 3 dogs. He lives outside the city. He lives in the coast, but like 8 hours by car or 9 hours by car from the city. He actually is a police officer, but he refers that he worked with cattle 1 year ago. He denies consumption of alcohol or other toxics. And yeah, well, he is diagnosed with allergic rhinitis, and that's all about his past medical history. Maybe I can then talk about his vitals exam and some more labs later. Okay, so I think that's it for now.
Zabin, do you want to jump in first this time? And quick question, Jan, do you mind zooming in a little bit just so the text is a bit larger on the screen? That'd be awesome.
Sure, I'll get that done.
Oh, sorry, I wanted to say, Jan, you just can put on the 3 dots on the right upper corner to put full screen also. That's easier.
Look at
I
all these
think-
tricks we're learning.
And next to Zoom. Yeah.
Thank you
How's
for
that?
that, Jan. Yo, I don't know. I feel like the needle hasn't moved too much for me. The pancreatitis in 2015 is definitely notable, and I'd be curious whether there was an etiology established at the time, if it was biliary or if he was drinking then. The cancer, as Hans said, the remote cancer, I would say if this was 5 years ago and it was considered cured, seminomas do have a high rate of cure, and it would probably, not be related to this presentation. Did I hear that he had a concern for a mass in the other testicle, though?
Yeah, so this last year he was found a new lesion on the other testicle. So his doctor asked, so he wanted to go further studies or maybe an orchiectomy, but he deferred treatment, and he
Right.
stayed. Yep.
So yeah, Hans, I don't know that testicular cancer tends to metastasize to the GI tract, and in a way that would potentially lead to luminal bleeding either, but I wouldn't exclude it. Certainly with that history, regardless, a close follow-up examination, both of the scrotum as well as cross-sectional imaging, CT scan to look whether there have been any metastases, and to define that disease, and then potentially to tie it with the recurrent presentation or not. That needs to be done in parallel, right? And so otherwise, I'm just reading some of the comments. Antonio, that's a great thinking that pancreatitis, the pancreas, the pancreatic duct does communicate with the GI lumen, right? And it's possible for really severe necrotizing pancreatitis to essentially be complicated and end up introducing some blood components or bloody looking products into the GI tract that would then come out the other side. I would that's a good potential way to connect it. It wouldn't be the most common or typical presentation of pancreatitis, but there's a first time to learn everything. I guess I'd be curious to hear more about Reza's Hemosuchus pancreaticus case, which is not something I've ever pronounced before. Steph, what do you think?
Yeah, I'll be honest. I am hesitating to link any of these diagnoses directly right now with the acute onset upper quadrant pain and melena. I think the group has come up with some nice possible ways to connect it with a history of pancreatitis, and if there's kind of residual structural injury there that would predispose to GI bleed. The ways that we could potentially link both the prior seminoma and the new mass. But I'm not sure. I actually think maybe one of the most helpful pieces of data for me to feel a bit more confident in what the likely causes of pain and bleed are knowing alcohol use is not a part of the background history. That could be an explanation for many causes of GI bleeding, from esophagitis and gastritis to chronic liver disease with associated portal hypertension bleeding, as well as the abdominal girth we're hearing about. So to me, in fact, that's probably one of the most helpful things, is that pertinent negative, making those kind of alcohol-related causes a little bit less likely. Ultimately, I agree with what Hans wrote. Doesn't change our plan. We need some labs. We need probably the endoscopy sooner rather than later if we find the blood loss has been quite dramatic, and we can see later if these past medical issues, which are a lot for a younger man who's 44, tie into what's going in now. But Kiara, we'd love some more info.
Love that discussion. Okay, I will give you some extra information. So vitals were normal. He had a temperature of 36.8, a heart rate of 82, blood pressure 130/80, respiratory rate 20, and OSAT in 98% on room air. Generally, he was well appearance. He wasn't pale. He wasn't actually appearance of losing active bleeding. On HEENT was normal. Cardiovascular was normal too. But pulmonary, he had decreased breath sounds on the right base of the lung. Also, his abdomen was distended, painful to palpation, and some shifty dullness, also dullness in flanks. Neurologic exam was normal, and well, of course, there was a palpable lesion in his left testicle, approx like 1.5 centimeters. You want some labs? Yeah. So his white blood cell count was 21,390. Neutrophils were 5,133, but eosinophils were 11,999. Hemoglobin was 14.7. Platelets were 2,807,000. I'm sorry, I confused with numbers, but yeah, eosinophils were very, very, very high, and white blood cell count also very, very high. And chemistry, so sodium, many labs. So sodium were 141, potassium 3.7, chloride, urea, creatinine, glucose, FOF, magnesium were normal. AST 13, ALT 14, ALPHOS 99, all those were normal. Total VLI 0.4, which was normal. Albumin 4, which was also normal. All the coagulation profile was normal. Amylase and lipase, amylase 72, lipase 63, they were normal. LDH 211, which was normal. And so some further labs, ferritin was decreased in 6. Normally it should be in our labs like 30 to 400. ESR was elevated in 20. There were some further labs like one day after, which D-dimer was elevated in 17.1, and that was concordance because a day after admission he had a decreased SpO2, so he had to go to the ICU and he had some mechanical support. So that same time he had an increase in the D-dimer. Also, some further labs were IgE, he had 397, which normal should be less than 100. C-reactive protein was slightly elevated, but procalcitonin was normal. Yeah, I should stop now. Yes. So that's all for now.
Wow, thank you. Lavin, why don't I make some comments on the exam and maybe let you give some thoughts on the CBC, which prompted a lot of rapid typing in the chat when Kiara gave us that. I think the exam, I think what's worth pointing out is right now, the vital signs are reassuring, right? And Kiara told us there was no overt sign of bleeding, but he is not tachycardic, which would be one of the first vital signs changes we would see with rapid blood loss. There is no hypotension right now. It looks okay. I think the other significant thing to take into account is that abdominal swelling that he reported now seems to be free floating fluid in the abdomen based on the fact the dullness of where it is shifts as he moves, which is consistent with ascites. And I think now we're really changing our problem representation to a 44-year-old man with a prior treated seminoma and bout of pancreatitis with allergic rhinitis, now with acute abdominal pain and new onset ascites and GI bleeding. I think we can really kind of shift some of that and think about this is a patient who has ascites. We'll have to figure out what it's from, if it's related to portal hypertension as we posed before or not, but that physical exam is really, really helpful even before we get any imaging. There's plenty more to talk about, but Zavin, want to share some thoughts on those very high eosinophils?
Yeah, I think the first thing I'll say is that when you're serum Eos are that high, and you have some organ dysfunction, you kind of have to assume or consider that the eosinophils are causing that organ dysfunction, which they absolutely can. Even when the serum eosinophils are lower, oftentimes the tissue eosinophils can be much, much higher, and that even mild serum eosinophilia can be sort of your signal for there being an eosinophilic process that is causing whatever problem you're dealing with, be that a lung problem, a GI problem, a heart problem, whatever. In this case, that abdominal pain, that GI bleeding, I would just assume again that it's absolutely related with this eosinophilic process. And then the question is just, what is this eosinophilic process? When the serum level is that high, some of the broader differential kind of gets narrowed a little bit. The primary eosinophilic syndromes, like the clonal diseases of that lineage of kind of myeloid cells gets enriched. Parasitic diseases get enriched. And then some malignancies, including, Hodgkin's, other lymphomas, but potentially solid tumors too, can cause pretty severe paraneoplastic eosinophilia. And by the way, just to comment that it's that total white count is 22, but it's the EOs that are elevating the white count, right? It's not the neutrophils. It's the eosinophilia explains that total leukocytosis. So I totally agree with sort of Steph's framing of that problem representation. I think depending on exposures, but just in general, even in the southern United States, for example, there's plenty of parasites you can acquire without traveling. So I think it's really important to check both the stool for O and P, to check serum schistosoma and strongyloides antibodies for exposures, and then consider that depending how this case go, steroids may be in this patient's future. So you may not want to wait until that strongyloides antibody comes back, and you may want to treat possible strongyloidiasis empirically, especially if steroids are going to be given, because that can exacerbate and cause a hyperinfection syndrome that can be very bad. So let me just, before kind of waxing more poetic, I definitely want to incorporate y'all's great thoughts in the chat. So Valeria, thank you for sort of broadening the parasitic and infectious differential of eosinophilia with that Fiesta mnemonic. I love it. Jasimran agrees with the O and P. The question of could eosinophilic esophagitis present this way so eosinophilic esophagitis usually has a milder presentation, a more subacute chronic symptoms of esophageal either sort of dysmotility or almost what feels like obstruction, and is often on the spectrum of sort of atopic diseases, and is usually relatively easy to control with diet, plus minus topical, plus minus systemic steroids. I don't think of it as it being very bleedy. It's more likely to cause enough swelling to obstruct swallowing than to bleed, from what I know. And certainly this, kind of multisystemic severe presentation would be very unusual. Yeah, so that's my thought on that. Sonia, let me catch up with that. So EGPA, Alec, Rebecca, Steph, anyone else? Do y'all, I don't know, have y'all seen or heard of vasculitis causing this degree of peripheral eosinophilia? I haven't.
I haven't, over 10,000 like this. I haven't either. But I know Sonia's on, she might be able to tell. It seems too high. We're in the profound hypereosinophilia range now.
Yeah. So I would, I think, and then with the ascites and everything, I don't know, that seems in the setting of just how severe the eosinophilia is, how severe its likely effect on the GI tract are. The ascites to me is, again, doesn't necessarily differentiate between the underlying cause of it all. So my priorities would be to sort of rule out / empirically treat possible parasitic disease. and then look for potential sort of disseminated malignancy with a CT and consider whether the eosinophilia could be paraneoplastic, and then simultaneously, sort of consider clonal kind of a primary myeloid lineage eosinophilic, leukemia or a primary hypereosinophilic syndrome by involving, hematology, sending sort of the relevant mutations, some of which are JAK2 driven, FGFR driven, doing probably a flow cytometry, and again, just getting subspecialty help early, both to make the diagnosis as well as to advise whether kind of, depending on how sick this patient gets, when we reach the treatment threshold with steroids to reduce the ongoing active kind of end organ effects that this severe hypereosinophilia is likely causing. And then, of course, anytime there's an opportunity to sort of biopsy involved tissue, both to evaluate for, what's going on, as well as to exclude infections, malignancy in those tissues, I think may be warranted. That's all I got. What do other people think?
I guess the only thing we haven't tapped on is Chiara has mentioned, as he's initially evaluated in the hospital, he gets worsening hypoxemia as things go. That's a whole other thread, right? We're saying whatever is causing this eosinophilia is likely the driver of the new onset ascites, of the GI bleeding. And now we've got hypoxemia on the list also. So I think many of the things that Zaven mentioned fit well, right? Many of these parasitic infections like strongyloides, right, have a life cycle that requires kind of going through the lung and causing respiratory symptoms. Any of the malignancies, we heard about this likely right pleural effusion on the initial clinical exam, what that is from and how much worse it's gotten. But we've now got yet another organ system involved by, what is seeming to be a multi-systemic process where we're prioritizing infection, cancer, and then primary hematologic eosinophilic syndromes. I'm excited to see where this goes. Chiara, do you want to give us some more?
Yes, of course. So you all are right. That high eosinophils lead to an organ dysfunction. So this is why he had that high D dimer and a subsequent decrease in SpO2, and a contrast CT at that time revealed left pulmonary artery thromboembolism. Of course, this was like a presentation of an organ dysfunction because of these high eosinophils independently of either cause. So he received enoxaparin for this thromboembolism, and he improved his pulmonary function. Of course, as eosinophils were that high, he received steroids because I know that you shouldn't give steroids if you have high eosinophils, but these eosinophils were that high that he was like that damage was worse than not giving steroids. So by this time, when he received steroids, eosinophils start decreasing slowly, and he started like feeling better. Another contrast CT revealed mild pleural effusion and bilateral atelectasis in the lungs with right predominance, and there were some nodules surrounding the epicardial fat of the heart, and of course ascites. He, of course, had an endoscopy. There wasn't an active bleeding, and of course he had biopsies from the lesions, but of course biopsies take time for the results, so I won't reveal the results right now. And I don't have the paracentesis analyzed. I don't know why. I'm sorry. But yes, this is what I also have for now until I reveal the final diagnosis.
And just to clarify, Chiara, what was the kind of Did they just take random biopsies and endoscopy, or did they find ulcers or other little nodules in the GI tract?
Like point lesions, but they were not active bleeding. Like there were like kind of erosions, but there was no active bleeding or a specific lesion. So they took many biopsies in the stomach and duodenum.
Got it.
Kiara,
So-
was there a CT of the abdomen by chance too? Or like any imaging of the scrotum or anything? Or do you want, or we don't get that information yet?
No, so just CT abdomen, but there were no impressive lesions, just the ascites, but
Okay,
no, nothing
Gotcha.
relevant.
thank you.
So I guess the new information we have now is he's got a pulmonary embolism. Richard brought up that, yes, there's this dilemma of coming in with bleeding symptoms, but also having a clot. Fortunately, it seems, the bleeding based on his hemoglobin and clinical course had resolved and was not significant. And it sounds like, Kiara, they were with the respiratory symptoms getting better. There was thought that this was a large enough kind of thrombosis to actually cause some of his respiratory issues, and that he did well with that. I don't think the PE is too helpful, though, as an additional diagnosis. We know he's systemically inflamed already. Many of the problems that we've suggested could be at the heart, driving the eosinophils and the organ damage, could also predispose to thrombosis. So I don't think there's too much signal there. We've got these pericardial nodules, though, that shouldn't be there. I don't have a great sense of any of the particular diagnoses that we've talked about that can cause this profound eosinophilia that could lead that. I don't know, Zavan, do you link that with anything kind of reflexively?
No, except that, some of the sort of parasitic like hyperinfection syndromes and life cycles, I've just sort of read enough about how widely disseminated some of these horror shows of parasites can be, that either that, or again, metastasis, or just foci of inflammation, or kind of conglomeration of inflammatory cells that can happen even with malignant processes. When it comes to myeloid leukemias, we call those myeloid sarcomas, for example, right? That can happen anywhere. It's basically just like a blob of leukemic cells that converge together and form a tumor anywhere in the body. So I think I'm still worried about all of the above things.
So the diagnosis is coming soon. I guess we need to kind of put our money down in terms of which of these processes could cause GI infiltration, maybe portal hypertension, if ultimately that's what the ascites evaluation showed, as well as kind of just nodular findings in other visceral organs. A lot of people in the chat have mentioned kind of schistosomiasis. Oh, and a testicular mass too, right? So we've got a signal in the GU system and the GI as well as hepatic system. A couple people in the chat have mentioned schistosomiasis. I think that remains a compelling kind of diagnosis that could potentially tie these things together. And I still think some of those primary hematologic conditions that Zavan, you mentioned, are just extremely important to kind of rule out too with pathology and clonal studies also. Looking at the chat, let's see what else we've got here. Zavan, how comfortable do you feel putting your money down in any of those categories?
And Kiara, one more question. Is it rural Peru or urban Peru?
She
No,
said
Cusqueña is
coastal.
still urban. So yeah. But
Okay.
as I think I also mentioned he worked in the rural area the previous year with cattle, but just to mention.
Yeah. I mean, I think just epidemiologically, probably parasitic infectious, I would guess might be more common. And then once that's ruled out, something neoplastic, that would be my order.
Yes, Mohammed, we're heading down to the histopath lab with you here. And Valeria is bringing, I never know how to pronounce that. How do you actually say? I've read it a million times in books. Anyone dare? Zavin, you got pancreatitis hemosuchus down. Can you?
I've always said paragonimus in English. I'm sure in different languages it would be more Latin sounding.
Yeah, but great point, Valeria, with some signal we have even in the pulmonary organs. Kiara, give us what you got.
Okay, so this is like an ongoing case. So I have the results, but still like in diagnosis. So the biopsies showed there were no microorganisms or granulomas, but there was diffuse eosinophilia in the stomach and the duodenum. So it was cataloged like an eosinophilic gastroenteritis. However, this was cataloged as probably secondary to neoplasm. He is like right now being checked by onco studies because they are thinking that this new lesion in his testicle is probably a lymphoma and that first lesion in his, I mean, the first cancer in his testicle was in another institution. It was outside Lima, and they think that there was a possibility that it was another neoplasm, and it wasn't, and it was never probably a seminoma. And they are thinking now that this new lesion is again a lymphoma, and they are correlating this high eosinophilia with lymphoma diagnosis, but this is an ongoing diagnosis, so I don't know for sure what's happening right now. I will know soon. But yeah, let's hope for the best.
That's great. And then I guess in his getting better with steroids, right, is a signal, maybe more for the non-infectious inflammatory categories that we came into. And just, yeah, what is an important point to know someone's medical history is what it is, but sort of just seeing if a different diagnosis in the past, if we knew it now, would fit into the current presentation. Awesome case, Kiara. I like that it's kind of unfolding still. We'll look forward to any updates that you have. Zavin, any final comments before we turn it over to Vale?
Wow, no, just really curious to hear about the outcome later. And just to I guess that, what used to confuse me about, and still sort of confuses me about a lot of these sort of entities that we say, eosinophilic pneumonitis, eosinophilic gastroenteritis, they're sort of like, they kind of describe what's happening, but they don't say why, right? So yes, this patient has eosinophilic gastroenteritis because they have gastroenteritis. And then when you look at the tissue, it's just like packed full of eosinophils, and we know that the eosinophils can do this, right? But they're not just like so many things that we always talk about in various CP solvers venues. It's not really like a final diagnosis, and it can very much be a secondary process, right? In this case, it's hypothesized that there's a tumor in the scrotum that is stimulating the bone marrow, the myeloid cells, the immune system, to overproduce eosinophils, and then those eosinophils go places and wreak havoc, right? So that's kind of how I think about it with a lot of these kind of clinically descriptive terms of eosinophilic blankitis. The confusing part comes in the example of like eosinophilic esophagitis, for example, right? Where it's a much more kind of organ limited process usually, right? And a lot of times it's a process that is almost like a locally mediated allergic almost situation that isn't as complicated, I guess, of a narrative that involves the whole body or some distant problem. So anyway, as with so many things in the body, the more I learn about eosinophils, I feel like the less I understand them.
Thanks, Evan.
I forgot to mention something. Sorry. So he had many negative exams that my case is all messed up because I just write it down. But he had many negatives. Parasitologic exams was repeated 4 times. They were negative. Negative sputum exam, negative for strongy, negative blood and urine cultures. Urine analysis was also normal. He received HIV, HTLV test negative, C and P ANCA, beta HCG, alpha fetoprotein, beta 2 microglobulin, IgM and IgG for fasciolasis were also negative. I forgot that details, but yeah.
Thanks,
Yeah,
Kara.
do you know if they underwent any of those kind of clonal eosinophilia, like mutation testing for Jack and the others?
No, I believe they will do those tests
Okay.
because this is like a big institute. So yeah,
Okay.
they will definitely perform those tests.
I'm also like, just in thinking about his old seminoma, I guess I don't know too much about sort of primary testicular lymphomas, but for most lymphomas, if there's going to be an undertreatment or a recurrence, 5 years is kind of a long time. It's just a late relapse if we're calling this a relapse, but also, with seminomas, once you have seminoma on one side, just in general, you are predisposed to contralateral, like a second primary malignancy on the other side. I don't know if lymphoma is like a second primary lymphoma in the other testicle is similarly, kind of more likely. But I will be holding my breath until at some point, hopefully, we hear from you about, what the path was from the orchiectomy or whatever.
All right, Vali, we'll turn it over to you.
Great. Thank you so much, Kara, for this case. And the discussion was amazing. I loved it. So we started with the chief concern of GI bleeding, and we can divide or classify GI bleeding by the location. So it can affect the upper GI tract or the lower GI tract. And importantly is that we should not forget that melena, even though it's more usually associated with upper GI bleeding, it can also be caused by colon pathology, especially in the right or the proximal colon. And then Stephen introduced a framework that I found really great because I hadn't thought about it. And the fact that GI bleeding usually presents painless GI bleeding. And when it's painful, we should think about perforated ulcers or something affecting the esophagus that could cause the irritation. And then we linked the past medical history of the patient with the chief concern. And we thought about Eosinophilic pancreaticus, which is the first CP Solvers podcast that I listened to. It was Reza talking about how he got to UCSF and discussed a case that presented with a patient with GI bleeding and had a past medical history of pancreatitis. And he thought about Eosinophilic pancreaticus because of a New England CPS case. I really recommend that. and he blew everyone away at the UCSF morning report. And so Eosinophils pancreaticus is bleeding from the pancreatic duct from a complication of pancreatitis because of a pseudocyst. And also linking the post-clinical history of the seminoma, the malignancy the patient had that could cause thrombosis, and that could cause ischemia, that could cause bleeding, or could cause portal hypertension, and could explain also the ascites the patient had. And then with the finding of hypereosinophilia, I got really, really excited because I love parasites. But also thinking about the differential of malignancies, such as lymphoma, that could explain that high of eosinophils. And well, a problem here is that the eosinophils themselves can cause the organ dysfunction, as we see in a lot of primary eosinophilic syndromes that have no other apparent cause. And then I will leave you with the fifth mnemonic, which are of causes of parasites that can cause hypereosinophilia, that include the trematodes, such as Fasciola, Schistosoma, and Paragonymous. Isospora belli, which is now called Schistosomiasis belli, Echinococcus, Strongyloides, Toxocara, and Ascaris that can also affect the GI tract. So thank you so much. It was amazing, and see you all tomorrow.
Thanks, everyone. Great to see you. Thanks, Kiara. Thanks, Jen. Fantastic job.
Thanks, Vale. Have a great day.
Bye.